So it's great to see these initiatives, Ishmeet, across different geographies. I guess one of my next questions is we would like to know in terms of going forward, how do you scale these initiatives up? Because I think that is where you will start seeing impact on the ground, and not just scale them up, but how do you make them sustainable? Because it's essential then that these programs continue into the future and get institutionalized within the government systems, which is as important to us as just demonstrating a particular project. What are your thoughts?
I think thanks again, Pallav, for the question. I think the design of all our interventions in the states and programs are actually, the life cycle is such that where we want to use our focus initially is to make the government align with the stakeholders of the government. I think working with the state governments is a integral part of all our programs, because at the end of the day we have to build their capacity to be able to sustainably deliver the same kind and quality of intervention and programming going forward to be able to achieve those outcomes. The outcomes cannot be delivered by the time a development partner is there. So therefore, our focus is to, one, work with the state governments to streamline the process, demonstrate to them, like I mentioned, the district saturation projects we are doing in Assam, Chhattisgarh, Bihar, etc., all to help the local government to understand as to what is the benefit of this entire action activities around digitization or building governance cadence, etc. I think once we are able to demonstrate that outcome in a microcosm of a district and actually show the benefit in terms of the health outcomes, building institutional deliveries, tracking of high risk pregnancy cases, improving the ANC coverage, PNC coverage, I think that itself allows and builds their confidence that this can be scaled up. So then supporting that scale up becomes important, building their capability becomes important, bringing the right technology partners in the period we are there becomes important, ensuring that the stakeholders at every level, the actors at every level, understand what they're doing, how are they using the tools, and how are the tools being maintained and the data being governed. I think that if that entire cycle could take anywhere between 5 to 10 years, but the idea is that it is important to transition and make sure that we are able to build the government infrastructure and the government capability to do that. And that's the core of all our programming. And I think it's great that the initiatives like the Ayushman Bharat Digital Mission, which the Government of India and NHA is driving, I think that becomes the architecture of public health in all the states. And how do we support the states to understand that architecture, implement that architecture? Again, forms a very strong foundation of all our programs.
Thank you, Ishmeet, for bringing up the conversation around ABDM, the Ayushman Bharat Digital Mission, and it's an entire digital architecture which has been framed by the NHA, the National Health Authority, in terms of actually digitizing our health infrastructure, right? Giving each Indian citizen a digital ID for their health, creating electronic health records. Not only that, but also creating a digital record of the practitioners, of the facilities, of the pharmacies, and actually creating the whole digitization of that architecture. I think it has far-reaching effects in all that we've discussed today. What we would like to know is in terms of organizations like Piramal Foundation and Digital Bharat Collaborative, what is the role that we see playing out there from the viewpoint of some of the conversations which we've just had, making this process sustainable, actually catalyzing this process going forward? Where do you see us coming in?
Thanks again, Pallav, for the question. I think, as I mentioned earlier, the Ayushman Bharat Digital Mission, ABDM, is actually a very fundamental program, I think, which not only standardizes the entire digital public health architecture, but also allows all the states to be able to then work against a standardized benchmark of processes, as well as registries, as well as actually a kind of a protocol which is required to establish the digital architecture. And what we do is that as the change agents which we want to play the role in supporting the building the state capacity, I think our focus is that how do we engage with the state agencies, the state NHA body, the state health department of health, to understand that architecture and then actually implement it. While the government of India has given tremendous amount of guidelines, etc., but I think interpreting the guidelines in the local context, ensuring that they create the right PMUs in the team, in the states, to be able to then process those processes, ensuring that district level, the facilities, the health workers are all creating their health records, their KYCs are done, the record is done, the facility registry and the professional registries are linked to the HRMS system of the Department of Health, so that they are maintained on a regular manner, and that in a form becomes the Aadhaar for all the health workers and facilities in the state. And the same thing is then replicated in the private healthcare space also, which requires to hold camps, to hold workshops for the private healthcare providers, to make them understand the architecture, what do they need to play, what are the benefits they see, how do we engage with the citizens to create their Abha ID. Building, again, the idea is to work with the state machinery to be able to facilitate that processes. Of course, initially we might have to do some hand-holding. Our fellows are actually involved in setting up those camps to do the Abha IDs, etc. But once that system starts rolling, then the district and the block facilities are able to do it themselves. The applications, all of them need to be ABDM compliant so that they're able to, again, follow the same protocols. Even the applications which we have developed, like the Amrit application for the Health and Wellness Center, which has all the 12 CPHC, comprehensive primary healthcare modules in it, it has to be ABDM compliant, so that it actually aligns to the ABDM requirements and ensures that the health records are made as per those protocols. And they become then interoperable. All the data then becomes, it's very essential, because then only the data can actually become interoperable. Patient who is attended by a private healthcare provider and it populates the health record, that same record is available to the doctor in the public health system when the patient goes there.
Their systems are able to read it.
Their systems are able to read it and then offer that continuum of care. The entire principle that if the health system has to provide continuum of care to every citizen, then it's important that all the health record which the citizen owns for themselves is actually available across, whether it's private healthcare system or the public. And that's only possible if there's a common digital public health architecture, and which is what ABDM provides.
So continuum of care is, even if I have accessed at a health and wellness center at a primary healthcare, I have the ability to go all the way to the tertiary hospital or the super specialty hospital, and my health record can be carried all the way there.
Absolutely. And the fact that the pregnant mother, when she goes there, they have their record and they know that she's a high risk case and she probably needs a C-section to be done because she's not had a pregnancy.
She doesn't have to explain her entire case history.
Earlier ANC records have captured the fact that chances are that due to either the placement of the fetus or whatever, she needs to have a C-section. So, and that's something which the patient may not be able to explain to the doctor every time she meets a new face in a public health system.
Absolutely.
But the records itself, so that continuum care is only possible if this entire ABDM architecture has been deployed seamlessly across, ideally speaking, all health facilities and all health workers in the state. And that's what we facilitate and support the state to do it, understand how it has to be done, what is the right kind of technology to be brought in, what is the right kind of hospital information system, the job aid tools, the applications, how are they made interoperable, how does the information carry forward, how does the citizen actually, ABHA ID gets created, the citizen gets a PHR application, which is also a part of the ABDM architecture, a personal health record application, which allows the citizen to actually access which facility is closest to their house, which are the doctors available there, whether all the drugs are available there or not, whether there's an O positive blood available in that facility or not. How does he call for an ambulance? Can he do a telemedicine service to attend to an immediate requirement? All that is available in the PHR, but that can only be provided if the state has implemented the ABDM architecture. That allows and facilitates that PHR app which the citizen gets to be able to provide multiple services. Unless the application doesn't identify my geolocation and the geolocation of the facility is not being mapped under the facility registry, there is no way the two can talk to each other.
So a PHR app would be an end user, a citizen application,
which allows him to see which is my nearest facility,
Correct.
whether that facility has a doctor or not, it has all the drugs, it has the blood, it has the ambulance to send me to pick up, it has the diagnostic facilities available or not, and whether I can do a telemedicine. So all that is possible if that entire public health architecture under ABDM has been implemented seamlessly, and that's the real benefit. So we have not only helped the state governments to implement this architecture, we've also supported in the adoption of the digital tools, as I explained earlier. We've also supported in doing action and communication and IAC information systems to the citizens, for citizens to adopt. So citizens come into the facilities, they are told about the PHR application, how do they use it, what are the options available there. So all that requires a lot of continuous engagement and the right toolkits to be available to all the facilities so that they are able to mobilize and communicate. The ASHA workers play a very critical role to reach out to the citizens. They need to communicate the benefit. So I think the implementation of the public health architecture requires a lot of effort, and helping the states decode it, building their capabilities, allowing the decision makers to do a proper governance of the system becomes very critical.